When Sarah Chen arrived for her shift at 11 p.m., she found the medication cabinet unlocked. Inside, vials of potassium chloride were missing from inventory. 3 vials gone in 3 weeks. She checked the logs. Each vial disappeared the same night a patient died, and tonight another vial was missing. Sarah looked at the patient board. Room 304 had a new admission. The pattern was repeating. Welcome to Dark Medicine. Every week we uncover the cases that hospitals tried to bury. If you believe the truth matters more than reputation, hit subscribe. Drop your city in the comments. We want to know where our investigators are watching from. Sarah Chen had worked as a registered nurse in the intensive care unit at St. Vincent's Medical Center in Portland, Oregon for 12 years. During that time, she had witnessed hundreds of deaths. Some expected, some sudden, all of them leaving an impact on the families left behind. In the ICU, death was an unfortunate reality that came with the territory. Patients arrived in critical condition, and despite the best efforts of medical staff, not all of them survived. But something had been bothering Sarah for the past 3 weeks, something she couldn't quite articulate at first, just a nagging feeling that deaths in the ICU were occurring more frequently than normal. October 2018 had been particularly difficult. 5 patients had died unexpectedly, all during night shifts, all in room 304. Each death was classified as cardiac arrest. Each one came without warning, despite stable vital signs hours before. The ICU at St. Vincent's was a 16-bed unit that handled the hospital's most critical cases: post-surgical complications, severe infections, traumatic injuries, and patients requiring mechanical ventilation. The unit operated with a nurse-to-patient ratio of 1:2 during day shifts and 1:3 during nights. Sarah typically worked the night shift, 11 p.m. to 7 a.m., 3 or 4 nights per week. Room 304 was a standard ICU room, identical to the others. Private, equipped with advanced monitoring systems, a ventilator, IV pumps, and all the emergency equipment necessary for critical care. There was nothing structurally different about the room that would explain why so many patients were dying there. Yet the pattern was undeniable. The first death occurred on October 3rd. Margaret Holloway, a 67-year-old woman recovering from gallbladder surgery. She had been stable all day, her vitals normal, her pain managed. Sarah had checked on her at 2 a.m. during routine rounds. Everything looked fine. At 2:47 a.m., the cardiac monitor alarm sounded. By the time the rapid response team arrived, Margaret was in full cardiac arrest. Despite aggressive resuscitation efforts, she was pronounced dead at 3:15 a.m. The attending physician, Dr. Raymond Foster, ordered an autopsy to determine the cause. The results came back showing cardiac arrest due to hyperkalemia, dangerously elevated potassium levels in the blood. The conclusion was that Margaret had experienced an unexpected electrolyte imbalance, possibly related to her post-operative medications. It was rare, but not unheard of. The death was classified as a medical complication. The second death came on October 9th. Robert Chen, no relation to Sarah, a 52-year-old man admitted after a severe asthma attack. He had been intubated and placed on a ventilator, but was responding well to treatment. Plans were being made to extubate him within the next day or 2. At 2:53 a.m., his cardiac monitor showed sudden arrhythmia, followed immediately by cardiac arrest. The response team worked for 40 minutes trying to revive him. He was pronounced dead at 3:34 a.m. Again, Dr. Foster ordered tests. Again, the results showed hyperkalemia. Again, the death was attributed to an unexpected medical complication, possibly related to the medications used during his intubation and sedation. Sarah remembered thinking it was unusual to have 2 hyperkalemia deaths in 1 week, but she didn't voice her concerns. She was a nurse, not a physician. Dr. Foster had decades of experience. If he believed these were natural complications, who was she to question his judgment? The 3rd death occurred on October 15th. Linda Morrison, a 71-year-old woman admitted with pneumonia. She had been improving, her oxygen saturation levels stabilizing, her infection responding to antibiotics. At 2:41 a.m., cardiac arrest. Dead by 3:22 a.m., hyperkalemia. That's when Sarah began to notice the pattern. All 3 deaths occurred during the night shift. All 3 occurred in room 304. All 3 happened between 2:40 a.m. and 3 a.m. All 3 showed the same cause: abnormally high potassium levels. Sarah approached the unit supervisor, Barbara Winters, a veteran ICU nurse with 30 years of experience. She expressed her concerns about the clustering of deaths in room 304. Barbara listened patiently, then explained that clustering was not uncommon in ICU settings. Sometimes deaths occurred in waves due to seasonal factors, particularly severe patients being admitted during certain periods, or simply random statistical variation. "You're looking for patterns where there might not be any," Barbara told her. "Death is part of what we do here, Sarah. You know that." Sarah accepted the explanation, but she couldn't shake the feeling that something was wrong. The 4th death came on October 21st. James Patterson, a 58-year-old man recovering from a heart attack. He had been stable for 3 days, scheduled to be transferred to a step-down unit the following morning. At 2:46 a.m., cardiac arrest. Dead by 3:19 a.m. The same pattern, the same room, the same cause. This time, Sarah didn't go to Barbara. She went directly to Dr. Foster. She laid out the timeline, the room location, the timing, the consistent cause of death. She suggested that perhaps there was something environmental in room 304 causing these complications. Maybe faulty monitoring equipment, maybe contaminated IV fluids, maybe something in the room's ventilation system. Dr. Foster listened, made notes, and promised to have the hospital's facilities management team inspect room 304 thoroughly. 2 days later, Sarah received the report. The room had been examined, the equipment tested, the 4 fluids checked, the ventilation system inspected. Everything was functioning normally. There were no environmental factors that could explain the deaths. Sometimes, Dr. Foster told her, patients just die. We do everything right, and they still die. It's the nature of critical care medicine. Sarah wanted to believe him. She wanted to accept that these were just unfortunate coincidences. But then came the 5th death. October 28th. Daniel Reed, a 44-year-old construction worker, admitted after falling from scaffolding. Fractured ribs, punctured lung, but stable condition. The lung had been repaired, he was breathing on his own, and his prognosis was good. At 2:51 a.m., cardiac arrest. Dead by 3:27 a.m., room 304. Hyperkalemia, 5 deaths in 3 weeks. All the same pattern, all the same room, all the same cause. Sarah couldn't ignore it anymore. That night, after her shift ended at 7 a.m., she stayed behind. She went to the medication room, a secure area where controlled substances and critical medications were stored. Access was restricted to nurses and physicians, requiring both a keycard and a PIN code. Every medication withdrawal was automatically logged in the computer system, recording who accessed the cabinet, what medication was taken, the quantity, and the time. Sarah logged into the system and pulled up the records for potassium chloride, the medication that, when administered intravenously in high doses, would cause exactly the kind of hyperkalemia that had killed 5 patients. Potassium chloride was a necessary medication in the ICU, used to correct low potassium levels in patients, but in excessive amounts it was lethal. The computer showed regular withdrawals of potassium chloride throughout October, all properly documented and accounted for. But Sarah noticed something odd. The inventory count didn't match the documented withdrawals. According to the computer logs, 12 vials of potassium chloride had been withdrawn during October. But when Sarah physically counted the vials in the cabinet, the inventory showed 15 vials missing. 3 vials were unaccounted for. 3 undocumented withdrawals. Sarah cross-referenced the dates. The first missing vial corresponded to October 3rd, the night Margaret Holloway died. The second missing vial matched October 9th, Robert Chen's death. The third corresponded to October 15th, Linda Morrison's death. Sarah's hands were shaking as she printed the records. The pattern was no longer just a feeling. It was evidence. Someone had been accessing the medication cabinet, taking potassium chloride without logging it, and using it to kill patients. But the dates didn't line up completely. 3 missing vials, but 5 deaths. Sarah checked the inventory records more carefully. She discovered that the inventory system only updated once per week, every Monday morning. If vials were taken between Monday counts, they wouldn't show as missing until the following week's count. Sarah pulled the inventory records from the previous weeks. 2 more vials had been marked as unexplained shrinkage on October 22nd and October 29th, the weeks of the 4th and 5th deaths. Hospital policy attributed small discrepancies to documentation errors or damaged vials that weren't properly recorded as waste. But Sarah knew better. 5 missing vials, 5 deaths. The correlation was impossible to ignore. The question now was, who had taken them? Sarah returned to the computer system and pulled up the access logs for the medication room. She filtered the results to show only entries during the night shift hours of 11 p.m. to 7 a.m. during October. 23 nurses and 6 physicians had accessed the medication room during those hours throughout the month, but Sarah needed to narrow it down further. She filtered the logs to show only access times between 2 a.m. and 3 a.m., the window when the deaths had occurred. The list shortened dramatically. Only 4 people had accessed the medication room during that time window on the nights of the deaths: Dr. Raymond Foster, Dr. Jennifer Okoye, David Morrison, a nurse, and Sarah herself. Sarah eliminated herself from the list. She had been present during the resuscitation attempts witnessed by multiple staff members. She hadn't been alone with any of the patients before their arrests. Dr. Foster seemed unlikely. He was the attending physician, well-respected, with no apparent motive. Sarah had worked with him for years. The idea that he could be killing patients was difficult to fathom. Dr. Okoye was a second-year resident, young and still learning. She seemed even less likely than Dr. Foster. That left David Morrison. David had worked at St. Vincent's for 15 years. He was one of the most experienced nurses in the ICU, reliable, competent, well-liked by both staff and patients. He often volunteered to take the least desirable shifts. He never complained. He was always willing to help colleagues who were overwhelmed. Sarah had worked alongside David dozens of times. She considered him a friend. The thought that he could be responsible for these deaths seemed absurd, but the data didn't lie. David Morrison had accessed the medication room between 2 a.m. and 3 a.m. on the night of all 5 deaths. Sarah decided to dig deeper into David's background. She accessed the hospital's human resources system, which maintained employment records for all staff. David's file showed that he had started at St. Vincent's in 2003. Before that, he had worked at Mercy General Hospital in Sacramento, California, from 1998 to 2003. Before that, St. Luke's Hospital in Phoenix, Arizona, from 1993 to 1998. And before that, Community Medical Center in Fresno, California, from 1993 to 1998, 1988 to 1993. 4 hospitals over 30 years. Not unusual for a nurse seeking better opportunities or relocating for personal reasons. But Sarah noticed something in the employment record. At each previous hospital, David had resigned voluntarily. No termination, no disciplinary action, just voluntary resignation followed by immediate employment at the next facility. Sarah knew she was crossing ethical boundaries by investigating a colleague this way, but she couldn't stop. She used the hospital's medical library access to search for published papers or news articles about unexplained deaths at David's previous hospitals. What she found made her blood run cold. A 2002 article in the Sacramento Bee reported that Mercy General Hospital had conducted an internal investigation into a cluster of unexpected patient deaths in their ICU. 10 patients had died over an 8-month period, all from cardiac arrest caused by hyperkalemia. The hospital concluded that the deaths were due to a series of unfortunate medical complications and medication errors. No charges were filed. No staff members were named in the article. David Morrison had worked at Mercy General during that exact time period. He had resigned in early 2003, just 2 months after the investigation concluded. Sarah searched for similar incidents at St. Luke's Hospital in Phoenix. She found a brief mention in a 2001 medical journal article discussing unusual mortality rates in intensive care units. St. Luke's had been cited as having a higher-than-expected death rate in their ICU between 1996 and 1998, but the article attributed this to the hospital serving a particularly ill patient population. Again, those dates aligned with David Morrison's employment there. Sarah couldn't find anything about Community Medical Center in Fresno, but the pattern was becoming clear. David Morrison had worked at multiple hospitals where unexplained patient deaths had occurred. Each time, he had quietly resigned and moved to a new facility before any serious investigation could focus on individual staff members. Sarah realized she was looking at a serial killer. A medical serial killer who had been operating for potentially decades, moving from hospital to hospital, killing patients and disappearing before being caught. The question now was what to do with this information. Sarah had no concrete proof, only circumstantial evidence. Access logs that showed David entering the medication room, but not proof that he had taken the potassium chloride. Inventory discrepancies that could be attributed to documentation errors. A pattern of deaths that could be explained as coincidence. And employment history that, while suspicious, wasn't evidence of a crime. If Sarah went to hospital administration with this information, they would likely dismiss it as speculation. If she went to the police, they would tell her to let the hospital handle it internally. And if she confronted David directly, she could be putting herself in danger. Sarah decided to gather more evidence. She needed to catch David in the act. That night, October 30th, Sarah arrived for her shift at 11 p.m. She checked the patient assignments. Room 304 had a new admission. Thomas Garrett, a 61-year-old man admitted earlier that day with respiratory failure. He had been intubated and was on a ventilator, but his condition was stable. According to the pattern, he would be the next victim. Sarah also checked the nursing assignments. David Morrison was working that night, assigned to rooms 302, 304, and 306. Thomas Garrett was David's patient. Sarah knew she had to act. She couldn't let another patient die while she gathered evidence, but she also knew that if she alerted hospital security or administration without proof, David would simply deny everything, and the investigation would focus on Sarah's accusations rather than David's actions. She decided on a different approach. She would watch David throughout the night and intervene if he attempted to access Thomas Garrett's room during the critical window of 2 a.m. to 3 a.m. The first few hours of the shift passed normally. Sarah completed her patient assessments. administered medications, documented vital signs, and responded to alarms. David worked quietly at the nurse's station, completing his own documentation. They exchanged pleasantries, discussed patient conditions, and collaborated on a procedure for one of Sarah's patients. To any outside observer, it was a routine night shift. But Sarah was watching David carefully. She noticed that he frequently glanced at the clock. She noticed that he seemed more tense than usual, his movements less relaxed. She noticed that around 1:30 a.m. he excused himself to use the restroom, but instead of heading toward the staff restroom, he walked toward the medication room. Sarah followed at a distance. She watched as David entered the medication room using his keycard and PIN. She waited outside, listening. She could hear the sound of the medication cabinet opening, the rustle of supplies being moved, then silence, then the cabinet closing. David exited the medication room 30 seconds later. His right hand was in the pocket of his scrubs. He saw Sarah standing in the hallway and froze for a moment. Then he smiled. "Couldn't sleep?" he asked casually. "Just restless," Sarah replied. "Quiet night?" "Too quiet," David said. "Always makes me nervous when it's this quiet. Usually means something bad is about to happen." He walked past her, back toward the nurse's station. Sarah's heart was pounding. She was certain that David had taken something from the medication room. Something in his pocket. Most likely a syringe filled with potassium chloride. Sarah returned to the nurse's station and positioned herself where she could watch the hallway leading to room 304. She pretended to work on documentation, but her eyes never left the corridor. At 2:35 a.m., David stood up from his chair. He stretched, yawned, and announced that he was going to check on his patients. He walked down the hallway toward rooms 302, 304, and 306. Sarah waited 30 seconds, then followed. She walked quietly down the dimly lit hallway, her soft-soled shoes making no sound on the polished floor. She could see David entering room 302, checking on his patient there. He spent 2 minutes inside, then exited and moved to room 304. Sarah positioned herself in the doorway of the supply room directly across from room 304. From there, she had a clear view through the window into the patient room. She could see Thomas Garrett lying unconscious on the bed, the ventilator breathing for him, the monitors displaying his vital signs. She watched as David entered the room. He stood beside Thomas's bed for a moment, checking the ventilator settings, adjusting the IV drip. Normal nursing activities. Then David reached into his pocket. Sarah's breath caught. David pulled out a syringe. Not a standard syringe from the medication room, but a smaller one, the kind used for precise medication administration. He held it up to the light, checking the contents. Sarah knew what was about to happen. David was going to inject potassium chloride directly into Thomas's IV line. Within minutes, Thomas would go into cardiac arrest. The monitors would alarm. Staff would rush in. Resuscitation efforts would fail. Thomas would be pronounced dead, and David would console the grieving family, expressing his sympathies. Just another unfortunate death in the ICU. Sarah stepped out of the supply room and walked directly into room 304. "David," she said firmly, "step away from the patient." David turned, the syringe still in his hand. For a moment, his expression showed surprise. Then it shifted to something else. Calculation. He was assessing the situation, deciding how to respond. "Sarah," he said calmly, "what are you doing here?" "I could ask you the same thing," Sarah replied. She kept her voice steady, professional. "What's in the syringe, David?" "Medication," he said. "Mr. Garrett's potassium levels are low. I'm correcting the imbalance." "That's not a medication from the automated dispensing cabinet," Sarah said. "That's a pre-filled syringe from your pocket. and Mr. Garrett's potassium levels are normal. I checked his labs an hour ago." David's expression didn't change. He stood completely still, the syringe held casually in his hand. "You're mistaken," he said. "I pulled this from the cabinet earlier." "No, you didn't," Sarah said. "I checked the access logs. You haven't documented any potassium withdrawal tonight." For several seconds, neither of them moved. The only sounds in the room were the rhythmic whoosh of the ventilator and the soft beeping of the cardiac monitor. Then David smiled. It was a cold smile, completely devoid of warmth or humanity. "You've been investigating me," he said. It wasn't a question. "How long have you suspected?" "Long enough," Sarah said. 5 patients, David. 5 people who trusted us to care for them." "Why?" David glanced at Thomas Garrett, still unconscious on the bed, unaware that his life was being decided in the conversation happening beside him. "They were suffering," David said quietly. "All of them. Do you know what it's like to watch people suffer day after day, hooked up to machines, pumped full of drugs, kept alive when they should be allowed to die with dignity? I was helping them." "That's not your decision to make," Sarah said. "Isn't it?" David replied. "We make life and death decisions every day. We decide who gets aggressive treatment and who gets palliative care. We decide when to continue resuscitation and when to call time of death. What's the difference?" "The difference is consent," Sarah said. "These patients didn't ask to die. Their families didn't agree to end treatment. You made that choice for them. Their families were prolonging the inevitable," David said, "keeping them alive for their own selfish reasons. I gave them peace." Sarah realized she was talking to someone who had completely rationalized his actions. In David's mind, he wasn't a murderer. He was a mercy killer, ending suffering, making difficult decisions that others were too weak to make. "How many?" Sarah asked. "How many patients have you killed?" David tilted his head, considering the question. "I don't keep count," he said. "Does it matter? They were going to die anyway. I just helped them along." "It matters," Sarah said. "It matters to their families. It matters to the people who loved them." David took a step toward the IV line. Sarah moved to block him. "Don't," she said. "Or what?" David asked. "Will you stop me? Will you call security? Will you tell everyone that you've been investigating a colleague based on nothing but suspicion and paranoia?" "I have evidence," Sarah said. "The missing vials, the access logs, your employment history, the deaths at your previous hospitals." David's smile faded. "You've been thorough," he said, "but it's still circumstantial. No witnesses, no physical evidence, just a paranoid nurse who couldn't accept that sometimes patients die." "Then why don't we test the contents of that syringe?" Sarah said. "If it's just standard medication like you claim, there's no problem. But if it's a lethal dose of potassium chloride, we'll have all the evidence we need." David looked at the syringe in his hand, then back at Sarah. His expression shifted again, this time to something like regret. "I liked you, Sarah," he said. "You were a good nurse, compassionate, dedicated. I'm sorry you got involved in this." He took another step toward the IV line. Sarah grabbed his wrist, trying to stop him from injecting the medication. David was stronger than she expected. He pushed her back against the wall, still holding the syringe. "Let go," he said through gritted teeth. Sarah reached for the call button on the wall behind her, the one that would alert the entire nursing staff of an emergency. Her fingers found the button and pressed it hard. Immediately, alarms sounded throughout the ICU. Red lights flashed above the doorway to room 304. Within seconds, footsteps pounded down the hallway. Other nurses appeared in the doorway, then security guards. David released Sarah's wrist and stepped back, the syringe still in his hand. Barbara Winters, the unit supervisor, rushed into the room. "What's going on?" she demanded. Sarah was breathing hard, her heart racing. "Call the police," she said. "David Morrison has been killing patients." The room fell silent. Everyone stared at David. He stood calmly beside Thomas Garrett's bed, still holding the syringe. "That's a serious accusation," Barbara said. "Check the syringe," Sarah said. "It's potassium chloride. He was about to inject it into Mr. Garrett's IV line." "Check the syringe," Sarah said. "It's potassium chloride. He was about to inject it into Mr. Garrett's IV line." One of the security guards approached David. "Sir, I need you to hand over the syringe." David looked at the syringe, then at the faces surrounding him. All the people he had worked with for 15 years. People who had trusted him, liked him, respected him. He set the syringe carefully on the bedside table and raised his hands in surrender. "I want a lawyer," he said. The Portland Police Department arrived 20 minutes later. They took David Morrison into custody, securing the syringe as evidence. Hospital administration was notified. The Oregon State Board of Nursing was contacted. The medical examiner's office was asked to review the deaths of the 5 patients who had died in October. Sarah spent the rest of her shift giving statements to detectives. She provided them with the access logs, the inventory discrepancies, David's employment history, and the information she had found about deaths at his previous hospitals. The investigation that followed was extensive. Toxicology tests were ordered on all 5 patients who had died in October. The results confirmed elevated potassium levels consistent with intravenous injection of potassium chloride. The syringe David had been holding was tested. It contained a lethal concentration of potassium chloride, far exceeding any therapeutic dose. Detectives contacted David's previous employers. At Mercy General Hospital in Sacramento, they discovered that the 2002 internal investigation had identified David Morrison as a person of interest, but the hospital had quietly accepted his resignation rather than pursue formal charges, fearing the negative publicity. At St. Luke's Hospital in Phoenix, a similar pattern emerged. The hospital had suspected David of contributing to the elevated death rates, but lacked concrete evidence. They allowed him to resign voluntarily. In total, investigators estimated that David Morrison had killed between 40 and 60 patients over his 30-year career, making him one of the most prolific medical serial killers in American history. David Morrison was charged with 5 counts of first-degree murder. His trial began in June 2019. The prosecution presented overwhelming evidence: the access logs, the missing medications, the toxicology reports, the pattern of deaths, and Sarah Chen's eyewitness testimony of David's attempted murder of Thomas Garrett. David's defense argued that he had been providing mercy killings, ending the suffering of terminally ill patients. They claimed he had acted out of compassion, not malice. The jury deliberated for 6 hours. They found David Morrison guilty on all 5 counts of first-degree murder. He was sentenced to life in prison without the possibility of parole. Sarah Chen continued working at St. Vincent's Medical Center for 2 more years after David's arrest, but the experience had changed her. She found herself constantly second-guessing her colleagues, watching for suspicious patterns, unable to trust the people she worked with. The psychological toll became too much. In 2021, Sarah left bedside nursing. She took a position with the Oregon State Board of Nursing, working in their investigative division. Her job now was to investigate complaints against nurses, identify potential misconduct, and prevent situations like David Morrison from happening again. She thought often about the 5 patients who died in October 2018. Margaret Holloway, Robert Chen, Linda Morrison, James Patterson and Daniel Reed. 5 people who had trusted the healthcare system to protect them, only to be betrayed by someone who had sworn an oath to do no harm. But she also thought about Thomas Garrett, the patient in room 304 who survived because Sarah had been paying attention. Thomas had recovered from his respiratory failure, been extubated, and eventually discharged home to his family. He never knew how close he had come to being David Morrison's 6th victim. Sarah often wondered if she could have acted sooner. If she had voiced her concerns after the 3rd death instead of the 5th, could she have saved James Patterson and Daniel Reed? The question haunted her during sleepless nights. But she also knew that she had done something critically important. She had noticed the pattern when others had dismissed it as coincidence. She had investigated when it would have been easier to accept the official explanations. She had gathered evidence when she could have remained silent. And ultimately, she had stopped a killer who might have continued for years. The case of David Morrison became a landmark in medical serial killer prosecutions. It led to reforms in hospital policies regarding medication tracking, mandatory reporting of unusual death patterns, and more thorough background checks for healthcare workers. St. Vincent's Medical Center implemented a new computerized system that flagged unusual patterns in patient outcomes and medication access, designed to detect potential serial killers before they could claim multiple victims. Sarah Chen never spoke publicly about the case. She declined interview requests from news organizations and documentary filmmakers. She didn't want to be known as the nurse who caught a serial killer. She just wanted to do her job, protect patients, and make sure that what happened in October 2018 never happened again. But in the quiet moments of her new career, when she reviewed investigative files and analyzed patterns of nurse misconduct, Sarah thought about that night in room 304, the moment she confronted David Morrison, the moment she chose to act instead of remaining silent. And she knew she had made the right choice, even though it cost her the career she loved and the peace of mind she once had. Because some truths are too important to ignore, and some patterns demand to be noticed.